saw this picture and I thought it was very apt. I mean, we've gone from the ape evolving, bending to finally standing, and then literally now going back, thanks to COVID, backwards. That's how I feel currently. I don't know how you do. Many years ago when I started medicine in 2003, one of the main reasons I picked medicine was so I wouldn't have to sit at a desk from 8 to 5. And thanks to COVID, a lot of that has not happened. So just so you guys are aware, and I'm sure these numbers are changing on a continuous basis, this is literally what is happening every minute as we speak with regards to social media, YouTube, Twitter, Instagram, Facebook. And I mean, I'm sure you guys are as bad as I am with social media. It's addictive, it's infectious. And I think the older I get, the more I'm realizing the harmful effects of it, especially when I see patients that are suffering because of it. So I want to start with this YouTube link that I have seen millions of times, and I'm sure you guys have seen it before I even brought your attention to it. So essentially, I mean, these themes have been mentioned before. The main topics of what went wrong in that situational awareness issues weren't addressed. There was major communication errors. And these are my ideas of understanding what it is. And I think my opinion of the video has also changed the older I've gotten and the more advanced I've become in medicine now doing my master's after completing undergrad and postgrad, and how things change when you have to be involved in the management of junior people. I think at one point, it was very clear who the team leader was in the beginning, and then that became very unclear towards the middle. And obviously environmental factors and human factors, which we'll explore. But essentially, I think the nurses, it's very easy when you are sort of standing back watching something happen. It's easy to say what is going on, and it's easy for you to give perspective, just like it's easy to have input with hindsight. And I think the nurses realized immediately something is going very wrong. But then, and I don't think the people were unapproachable, the doctors weren't unapproachable, they just obviously felt in that scenario their voices weren't going to be heard, perhaps because they were the nurses and the doctors were the doctors. Obviously we'll never know. And I think the most humbling and touching aspect of that video for me is Martin Bromley saying that all the doctors involved did eventually go back to work, and that's exactly what he wanted. And I think for me that really is a take-home message from that video. Having been involved over the years in my own critical incidents or serious events, or being in charge and then assisting my juniors, I think that's so important. And then that also brings in the aspect of mental health, which I hope I can touch on briefly. So essentially, human factors involves multiple subtopics or core ideas, of which leadership is one, teamwork is another one, there's workload management. We've already spoken about situational awareness, as well as decision-making and communication. I'm not sure how many people of you actually know this, but I didn't know this until we recently had a meeting where someone broke down that the majority of communication is not actually what you say, it's how you are expressing yourself through your body language. And that only 7% is made up by the words that you are, that are coming out of your mouth. And that 38% comes from your tone. So this is something, again, that I've recently learned, and it is so important. And I wish I had been taught this in my younger days in med school. It's essentially personal factors with the mnemonic of HALT. And again, you'll see the senior as you advance in your career, not even as you become senior, just as you advance over the years, you'll realize that you know some colleagues really well, others that you don't. And especially the ones that you don't know well, you may come across days where they're just not themselves. And especially from an A&E perspective, where we have to interact with essentially the whole hospital and all the different specialities. I always ask myself, how many personal factors are taking into, or do I need to take into account if I'm dealing with someone that's difficult, especially if they're not normally difficult and their baseline is, they're generally a nice human being to work with. So essentially, it's, are they hungry? Are they angry? Are they late? Are they tired? And again, this brings me to the next thing, which I have recently started using myself. And this is essentially used in major casualties or mass casualties. And it's essentially how you identify any threat. And I don't mean threat as in a bomb threat. I mean a threat to your state of mind. So the mnemonic is, as you can see, PET lab, where P is physical, E is environment, T is task, the other T is timing, L is for learning, E is for motion, and P is for perspective. And you can literally do a whole body scan from head to toe in 1 minute and ask your things. How am I feeling physically? What is happening in the environment at the moment? What task do I need to focus on? And what is the most important task I need to focus on? Do I need to delegate? Do I need more people? How much time do I have? And how much time is each task going to take? What are the learning points? How am I feeling emotionally? And do I need any additional perspective? And for me, that perspective would be calling for help, calling another senior. And often we have multiple seniors. And I mean, it's 2 heads are always better than 1. So essentially, I've just explained the 3. So when you go through the PET lab, you are essentially identifying 3 states within you, which is the physical state, the emotional state, and the cognitive state. And by doing so with the physical state, you're essentially softening your stance, you're being able to breathe. And I mean, there's times where I just think I'm in a scenario, everything is going wrong, or it's a really difficult case, it's a rape case, or it's a polytrauma case where there's multiple children, or it's I can't think of any, if it's a mass casualty with a pregnant woman, I just think inhale, exhale, repeat. And I often say that to myself, and I'll say that to the team members as well. And again, the trigger word is focus. What are you focusing on? Am I focusing on an airway? Am I focusing on disability? Am I focusing on breathing? What has the team leader told me? And at the same time, what is my emotional focus? And I'll talk about the ATE assessment because that's obviously the lecture that follows. And then the last part is, the cognitive state, how you're feeling and what you're going to do to move on, especially in the cases where you've had a bad outcome, and especially in the cases where you didn't expect a bad outcome. So this slide is essentially the difference between 2 words that are very much associated with human factors, one being cognitive load and the other one being bandwidth. So essentially, cognitive load is the amount of mental resources used in working memory to do various tasks, whereas bandwidth is essentially your internet connection in your space. Do you have a weak or good internet connection? And it's your mental capacity that is needed to deal with a specific situation. I think the key take-home message for me, for you guys, would be it's okay to not be okay. And you can't help other people if you're not okay. We as medical students or as medical practitioners, allied healthcare professionals, we really struggle to come to terms with not being okay because we think we're all heroes. We need to be okay 300% of the time. We're all type A personalities. We strive for perfection. And you know what the reality is that we're really not all that. And we're human, just as the person sitting next to you, on the left of you or the right of you. And like I said, the older I've become, this is a topic that's grown even closer to my heart. And I've started to appreciate the different levels and the different states of mind that my body is in, that I'm physically in, and that I'm emotionally in. So just to break down cognitive load, there's essentially 3 aspects of it, which is the intrinsic, which helps you simplify, the germane, which helps you maximize, and the last, the extraneous, which makes you reduce. So, I mean, you can all read the slides. I'm not going to just repeat what it's saying, but it's essentially being aware of these aspects. And again, it's situational awareness of what's going around you, as well as your internal response to what's happening. So in terms of simplify, the way you simplify things, these are your buzzwords. You establish, you incorporate, you utilize. And in terms of establishing, you always need to establish and work towards a common goal, especially if you've got, for example, a polytrauma and one patient with multiple injuries. You can't fix everything. You need to obviously fix life over limb. What's the most important? We've recently had a pregnant woman in a very bad car accident. And I mean, I think we knew from the beginning, the only way to save the mom was to get that baby out, and that child was not ready to be born. So we knew that that was going to be a stillbirth. And at that point in time, also, we're not allowed visitors with COVID at the moment. Her husband hadn't even been called. She's already been intubated on scene. So there's multiple things going on in your head, and you need to be able to distance yourself, and easier said than done, to appreciate what your goal is and what you're going to work towards. And I think it's really important to share your thoughts and to share your decision-making process, however junior or senior the rest of your team is. And always, always use guidelines, your standard operating procedures, use your checklists. Um, I'm sure you guys are familiar with the SBAR handover when you're doing a handover. It's a very brief but clear and concise structured approach, which is essentially situation, background, assessment, recommendation. And the SORT and SIV, which is normally used in mass casualty events again. And then just in terms of reducing your bandwidth, it's essentially, again, just closed loop communication, team briefing before, during, after the event. And there's something that Oxford do that I've never done before that is amazing. That's something called hot and cold debrief. So when we've had a bad scenario or a patient that demises, we have a hot debrief, which means immediately after the incident has occurred, we all get together as a team, we debrief about it, and then the team leader will run it. And 2 weeks post the event, we have what's called a cold debrief, where we go through it again, and we're basically checking mentally, physically, emotionally, how everyone has coped and dealt with what's happened. And again, early preparation, and I appreciate this is not always possible because sometimes the ambulance say they're 5 minutes away and they show up in 5 seconds. Sometimes they tell you they're 50 minutes away and they show up in 10 minutes. And sometimes we don't even get a pre-alert to say how far away they are. And obviously there's something called confirmation bias in that, for example, the ambulance is saying this patient has a tension pneumothorax, they've decompressed and the patient is still not better. And then you think, okay, why is the patient not better? Does the patient have another tension pneumothorax or have I missed something? And am I just focusing on the tension pneumothorax as confirmation bias and maybe missing a ruptured spleen in the abdomen? Again, this is a case we had about 10 days ago. We were all so focused on the tension pneumothorax until we called for help. And the person outside the loop was like, hang on, go back to A, B, C, D, E. Everyone is so focused on the tension pneumothorax. We've decompressed the one side, decompressed the other side. Why is the patient not getting better? Let me just change screens again. And in terms of maximizing, it is so, so important to have simulations and structured training and just to keep educating. I've been an ATLS instructor, I'm an ALS instructor, and I remember thinking when the consultant came in to say, you know, have you thought about other reasons for why this patient is not responding to the decompression? I had a moment and I thought, Natasha, you should know this. You've been doing A&E for 8 years. You're almost a consultant yourself. But you forget. And it's the simple things. The patient is right in front of you. The whole team is thinking, you know, all have the same thought process, the same thoughts. And then you're sharing your mental model where everyone is on the same page, which is both in this particular case was equally good and equally bad in terms of what we were offering the patient. I've spoken about the debriefing and re-reviewing. I'm not sure what the case is over there, but with us, we have educational and clinical supervisors that really help you when you have difficult cases. And even when you get good cases, I mean, we don't just share the negative experiences. So essentially the take-home messages are just a reminder of HALT and PETLIP and the mnemonics to essentially maximize the germane load, manage your intrinsic load, and minimize your extrinsic load. Any questions or anything you want to say or add?
I feel like it's a fairly universal experience for medical students to feel very in the way a lot of the time, especially when it's very busy and things are like very serious things are happening. How do you think there's any way for medical students to kind of tell if their suggestion would be being in the way or a useful one? Because obviously sometimes we also don't know if what we're seeing is what we're seeing, you know.
It's a really good question. And I actually got asked that 2 days ago by one of my own medical students. And she just said to me, she's like, I just feel useless in A&E because I never know exactly what you said, when to say what I'm feeling or when it's the right answer or what if I shoot out the wrong answer. And the way I went around it in med school, which is, although it was very many, like I said, very, very many years ago, I would literally go onto the shop floor and tell the senior most person, this is my name, this is what I want to do, this is what I don't want to do, this is what I'm comfortable with. So use me as much as you can. And I think if you as a medical student set the intention for the next 8, 10, 12 hours of your shift you've put out there to the person what you want to do, what you feel comfortable doing, and what you don't feel comfortable doing. And I think having done that with my own students when I've had them on rotation, that's really worked. For example, I've got a med student who's really interested in sports medicine. Putting that person in the resus room is not useful to him or me, and it's going to upset us both. Whereas if I put him into minors and I can review all the x-rays that he's seeing and teach him, that's huge. Whereas I'm winning, he's seeing patients that he wants to see, I'm seeing patients that I want him to see, and that way it's a win-win. And I think that's the most important thing, is to set your intention and don't be afraid to say, you know, this is way out of your depth. And again, you guys are all, just because you're medical students, it doesn't mean that you don't have your own HALT factors or your PET-lib factors, or exams are coming, or you're just tired. And again, some people hate A&E, but it's a mandatory rotation. So don't feel afraid to say, I wouldn't say I hate A&E. You come across to the doctor and say, you know, A&E is not one of my favorite specialities. I'm really nervous about this. What can I do, to better it? And you'll be surprised at how many pearls of wisdom the other people may have for you. Does that answer your question?
Yeah, it does. Thank you.
One is written in the chat. There we go. I'm just reading. Most of the time I feel hesitation and I couldn't say the answers or the thoughts I have in my mind because I'm afraid to be wrong. I can tell you now, I have been wrong a million times. I was wrong yesterday, my entire shift, where I came home and I thought I should probably quit A&E because I was just, everything that could go wrong was going wrong. And I came home and I spoke to my mom and I was debriefing. And then she said to me, Natasha, how many died? And I said none. And she was like, well, then I think you're okay. And you know what, by being wrong, the patient isn't going to die, especially if you're in the range or in the level that you guys are at the moment. And you know, sometimes it's inevitable, and very rarely, if the patient is dying, especially in our scenario, are you going to be alone. So don't be afraid to be wrong, because there will be so many times. I appreciate that puts you under pressure, but I think that's part of life, and I think that's why I like A&E so much. I've learned, and that's why I picked A&E. A&E for me is the best 10 minutes of every specialty, and I also have a bandwidth of about 10 minutes before I get bored. So after 10 minutes of stabilizing and stopping the bleeding, I've had enough of you, and then I will send you on, unless you know you require 30 minutes or 40 minutes of stabilization. I think it's really important to voice that you don't feel safe or that you're out of your comfort zone, but do it in a space where you feel comfortable. Don't do it in handover where there are 30 people. Speak to your supervisor and tell him or her to speak to the person on shift. There's ways around that. At least that's been my experience, and that's how I've been with my medical students.
First of all, I am Hamid Al-Habil at Leicester University, Gaza. Thank you for this amazing lecture. Actually, what I have is, how can I, as a medical student right now, for example, I'm going to the hospital for, for example, in the clinical years, for some rotations, how could I, for example, handle or adapt the pressure that we have on the hospital? For example, like we are seeing many scenarios, for example, patients dying, for example, their families are yelling at the doctors, and all these cases that we see at the hospital. So from your point of view, how can I deal with all these, pressures?
Thank you for that question. Thank you for your kind words. I think two things that have come to mind with listening to the question. One is coping mechanisms, which I'll come to in a minute. And two is the screaming relative of a patient. I think experience has taught me that 80% of the time that screaming relative is upset about something that is not being communicated, or it's misplaced anger. And essentially all you need to do, not you specifically, is you need to find someone that can go to this relative and say, this is where we're at, and apologize to them, not for what's happening, I mean, not for what you're doing, but for what's happening in the situation. And say, I'm so terribly sorry to be meeting you in these circumstances. And I assure you we're doing everything we can. I am the team leader and I'm going to go and stabilize your relative now, but Susie here is the healthcare assistant who will deal with you and ask you all your questions. And it's just literally, I mean, I had this again, I think it was last weekend on my nights. I said, is there anything I can do for you? Is there anyone I can call? And it's a simple things. We're all human. And I mean, yes, you get the patients that you just want to pull your hair out and they give me gray hair. And no matter what you say to them, there's just no winning. Those are not the norm. But it's little things of, is there somebody I can phone for you? Can I get you a cup of coffee? Can I get you a glass of water? Is there one main thing that's upsetting you right now that I can try and fix? And I think, again, it's situational awareness and trying to find out what their halt factors are and what their pet lib factors are, which is why I love it, because it's not just applicable to medicine. And like, as you heard Martin speaking about, it's applicable to aviation as well. So that was the one thing I would advise. And in terms of coping mechanisms, I think it is so important from an early age in your medical careers to find things to do that are non-medical. I'm sure all of you, just like I do, 90% of my friends are all medical, and I'm not sure that helps, because every time we go out, all we speak about are other medical things. While that's healthy and you need to debrief, it is so important to do non-medical things. So find that non-medical thing that is your coping mechanism, and develop a skill in that so that it is your go-to coping mechanism, whatever it may be, whether it's playing cricket, whether it's yoga, whether it's meditation, whether it's writing, whether it's cooking, it's baking, find it, because I promise you all have it in you. And I think that is the most important thing, is to find that coping mechanism, because the older you get, the shittier your shifts get. There's no easy way to say that. Does that answer your question, Mohammed?
Yes, thank you.
Okay, right. So this is in terms of the A&E assessment. So in terms of what the aim is of the A&E assessment, it's essentially a systematic, structured approach which focuses on each system. And again, it's always life over limb. So it's essentially identifying the critically unwell, your deteriorating patient, and what system is life-threatening that we need to fix, and what interventions we can do to prevent you from deteriorating further. And then obviously the whole idea of reassessing and reviewing with regular assessment to try and improve each problem that you can fix. So in terms of airway, where it starts is the patient talking to you? If the patient is talking to you, the airway is patent. So you will have your screaming patient that's coming on a stretcher, screaming blue murder, severe acute abdomen. Am I worried about airway? No. As long as they are screaming, I'm happy with airway. So there's a problem in B, C, D, or E if they're screaming. Obviously, it's different if the patient is screaming and is completely confused and wanting to jump off the bed and needs sedation. But I'm talking of the norm patient, where the patient is talking and responsive, and then you're not worried about A, so you're moving on to B. So when you are worried about A and the patient and the airway is not patent, you're looking for signs of airway compromise. And these can be various things. It could be in the form of soft tissue swelling. It could be a burns patient. They could have a massive goiter or a massive tumor. It could be angioedema from anaphylaxis, where their lips are really swollen. They could have a roaring quinces inside. They could even have Lidwig's angina. They could have a blocked stone in the salivary duct. It could be a respiratory issue where they are seriously distressed in that they have seesaw breathing, they're full of secretions, they're cyanotic. There's a foreign body that's been dislodged. There's a whole lot of blood or vomit that you can't see. It's deeper down that needs suctioning, or they may have an altered level of consciousness. And don't forget the simple things that you can do, which are your head tilt, chin lift, and your jaw thrust. And you can always put in an OPA and an NPA, and patients that are not tolerating an oral or nasal pharyngeal airway is a good thing, because it means the airway is not so bad. And then again, simple things, suction your secretions. Just remember, at the moment, all these things, so minus head tilt and jaw thrust, would all be a aerosol generating procedure. So you'd need to be in full level 2 PPE to be doing that, to prevent your own risk of getting any aerosol particles. And then moving on to B, it's just a quick look, listen, feel, auscultate. Look, listen, feel. Are they breathing really hard? Are they struggling to breathe? Are they going to get tired very quickly? Is it a DKA patient that is showing you Kussmaul's breathing? Or is it someone that is having chain stroke breathing? What are their breath sounds like? Are they cynosed? Are they cynosed centrally, just around the mouth, or sternal cyanosis, or is it all the way down with peripheral cyanosis? And when you expose the patient, just remember simple things like, just look at the chest, take a minute in all the franticness of the situation. Can you see a pigeon deformity? Is there a flail chest? One side is not moving. Look at their JVP. Remember to turn them and then look at their neck and make sure the bed is popped up at about 45 degrees. Is this someone that looks like they're having severe asthma where they can't complete sentences? Does this patient look like they've got florid pulmonary edema where you can see they've got pitting edema up to the knees? Is it somebody who's COPD, who you're worried about with saturations of 88, and then you think, hold on, this patient is retaining CO2. So saturations of 88 in a COPD patient is actually okay. And again, it's just going back to basics. And the thing that I remember the most from one of my professors in med school was that common things occur commonly. So exclude all your life-threatening common things first before you start thinking of your fifth and sixth differential. In terms of breathing continued, are they expanding their chest? You're not necessarily going to check for whispering pectoraliquy and vocal fremitus in your A&E patient. That A&E is, first of all, too noisy, and this patient is probably going to be too difficult for you to assess. But what you can check is, do they have dullness? Is it stony dull? Is it minimal dullness suggestive of consolidation? Are they resonant? Is it hyperresonant? Feel for their trachea. Is it deviated? Is it contralateral deviation? And then obviously you exclude your big things. Is it a hemo? Is it a pneumo? Is it a hemo-pneumo? Or is it a tension? And if it is a tension, you're going to do urgent decompression in your mid-clavicular line, second intercostal space, followed by an insertion of an intercostal drain. And that will be in the fourth or fifth intercostal space in your mid-axillary line. And just remember, you need to repeat your chest x-ray pre and post procedure to see if there's difference. And when you're putting in a drain, it's simple things like make sure your drain is bubbling, the tube is swinging, the patient is clinically improving, the repeat chest x-ray looks better, their saturations have improved, their hemodynamic instability has improved. And at the same time, listen to the patient. Again, are you hearing scattered coarse creps, which then fits with your bat wings, for example, on your chest x-ray, which would then be indicative of your cardiac failure? Are there no breath sounds at all? Is this a person who's having bronchial breathing? Is this a person who's got stridor because there's an epiglottitis or a foreign body that's been stuck? And then in terms of investigations for your breathing, you want to check their arterial blood gas ideally, but otherwise start with your venous. Make sure you've done your chest x-ray and consider non-invasive ventilation in your patients that are retaining CO2, like your COPD patients. Always start with the simple things, 15 liters of a non-rebreather, and then work your way up. Sorry, in terms of circulation, the things you want to check for are your temperature, your heart rate, your BP, and everything you want to check. Is it normal? Is it increased or is it decreased? Hypothermia, is it heat exhaustion? Is it heat stroke? Is it malignant hypothermia? Is it sepsis? If it is sepsis, you obviously need to do your sepsis 6 bundle immediately, which is give them oxygen, take blood cultures prior to giving antibiotics, and that's also adhering to your antibiotic guidelines. Give them a fluid challenge. And this doesn't mean that every patient needs a liter. If they have severe heart failure, you can go in boluses of 100 mils every 5 minutes and then review, or 150 mils, or even 200 mils or 250 mils. You can recheck your lactate, serial lactates on your blood gas, and then obviously they need a catheter aiming for 0.5 to 1 milligram per kilo per hour of urine output. Again, assess their heart rate. Is it a tachycardia from anxiety, from fever, from sepsis? Is it a tachycardia that's going into a major arrhythmia that you need to worry about, something like a pulsed VT? Is it a bradycardia that you can do something about? Is it a sinus brady that you're not going to do anything about, or maybe just give some atropine? And is it a heart block? 2nd degree heart block, atropine's not going to work. 3rd degree heart block, atropine's not going to work. So call for help early. Make sure you're not just going on your rhythm strip that you can see on the monitor. You need a full 12 lead ECG. And again, the same with your blood pressure. Is it too high? Is it too low? Remember your blood pressure autoregulation curve. You don't want to bring it down or increase it more than 25%, because then your patient is going to be at increased risk of developing a stroke. How are they peripherally? Are they shut down? Are they warm? Are they cold? Are they clammy? Is their cap refill delayed? Is it more than 3 seconds? Are you worried about hypervolemia? And if you're worried about hypervolemia, you need to work out, does this patient need fluid or does this patient need blood? There's a common saying with blood on the floor and 4 more. So if you see blood on the floor, that means there are 4 other places that are bleeding as well. So just something to keep in mind, especially with major trauma. So what are you going to be assessing for circulation? So essentially, again, look at your JVP, feel your pulses centrally, peripherally. Is it good volume? Is it a regular pulse? What is the rhythm? Can you feel for sacral edema? And while you're looking there, is this patient really poorly in that they've got pressure sores and that you're concerned about a non-accidental traumatic injury? Has the patient have a pneumoma? This you're going to have to correlate with previous notes and documentation, which is not always possible. And then remember your Beck's triad: hypertension, muffled heart sounds, and an elevated JVP is cardiac tamponade until proven otherwise. If it's a young patient, you want to exclude pregnancy. I know simple urine dip, your specific gravity, your ketones can be really helpful in assessing hydration. Make sure they've got 2 large bore lines. You're measuring your urine output. Your baseline bloods are done. Does this patient need a catheter because their bladder is full? And then remember your contraindications in trauma for putting in a catheter. If you've got blood at the urethral meatal tip, that's one of your main reasons for not doing it. Again, your ECG is part of your circulation. And is there somebody that's competent that can do a quick fast scan? Because remember, these ultrasounds, although CT is your definitive and is your most useful diagnosis, the fast can be repeated and you can do the fast while somebody else is doing something else. It's non-invasive. It's pretty accurate. Studies have shown that, and it can detect up to even 150 mils of fluid, whether that's blood or fluid. In terms of interventions, we've already spoken about fluids, and I've already said just be careful with cardiac failure, don't fluid overload them. We've spoken about the importance of antibiotics. Again, try and get some collateral with the sample history to try and ascertain if they've got any allergies. You don't want to be giving someone that's penicillin allergic penicillin. And do you need to activate major hemorrhage protocol early? And you rather activate it and then step them down. That's essentially the way to go, because prevention is better than cure. Is it someone who has a massive ST elevation MI where you're worried about acute coronary syndrome and you're going to go down the aspirin, the clopidogrel, the fondaparinux? You know, is it someone that needs to go to cath lab? Is it someone who's sepsis? And again, you've got your sepsis 6 bundle. Just very quickly, your major hemorrhage protocol. I remember when I was a med student, they used to love asking what makes up major hemorrhage protocol. So it's essentially your FFPs, your red cells, your cryoprecipitate, and your platelets. I don't think they'd ever ask you the right side of the algorithm, but just so you have a vague idea. And then the importance of giving tranexamic acid immediately in a traumatic scenario. Often in the UK, it's given on scene, and then when they come to ED, we continue the 8-hour infusion. Also remember your pregnant patients, do they need anti-D? And do you, especially in your patients that you're still waiting for your cross-match, emergency blood is going to be O negative. So I think your take home from this slide is essentially that the major hemorrhage protocol, you want to give TXA. Most patients will get O negative blood while waiting for the cross-match, and it will be 6 units of red blood cells and 4 units of FFPs. And then you decide on the further right-hand side of the slide how much more you want to give. In terms of your disability, so most people struggle with assessing your GCS. And again, that's not something you need to, that's going to change your management imminently, because if their GCS is less than 8, they need a tube essentially. But you'll see that when you're assessing A already. So by the time you've got to GCS, if you've got a GCS of 8, it's too late. You should have tubed them when you were at the very beginning. So the quicker way to assess level of consciousness would be your AVPU score, which is alert, verbal, responding to pain, or unresponsive. What their sugar is, and have they had any seizure activity? Look in their eyes. Is it pinpoint? Is it dilated? Do you think this is toxin induced? Have they got a blown pupil after trauma, which is suggestive of a blowout fracture? And then you need to call max fax early. And don't forget how many things can mimic a stroke or a seizure, including toxins. So when you have an unconscious patient, the first thing you will do is check their glucose after you've made sure they're stabilized. And that's a very quick, easy fix. You can repeat it. And like I said about imaging, your definitive thing is obviously to get them a pan CT scan, especially if you're going to be doing everything. Otherwise, if it's a young patient, limit what you're going to be scanning. And then in terms of exposure, it's essentially everything else. So your main two things of exposure will be their glucose level and their temperature. But the other things you want to check for under your primary survey is what their pain response is. Do they have any wounds? Are there, any drains that you don't know about, especially if you don't have a collateral? Do they have any life-threatening rashes? Are their calves soft, or is there a massive DVT that you're missing? Is this someone with a history of intravenous drug use that you are going to struggle with a line, which will then tell you need to get the ultrasound early and do cannulation or call for help? And is there any active bleeding or anything active that you've missed? So, for example, when you expose them, you can see bowel evisceration, which you hadn't before. Remember, with things like that, you want to give them a tetanus booster as well. And just simple things, if there is massive bleeding, can you pack them in the ED with Surgicel? Or there's often different companies that have different things of you can just pack it, or is it just something that needs pressure? Is this major hemorrhage, a DVT, then you want to thrombolize? Is it somebody with a major PE? So think of your H's and T's. They don't always apply in a cardiac arrest. Your H's and T's are also really helpful reversible causes when you're doing your A to E assessment. The sample history that I spoke about is essentially signs and symptoms, A is for allergy, M for medications, your previous medical or surgical histories, P, L is the last meal, and E is your events surrounding the incident, which should literally take you less than 5 minutes to ask this to either the paramedics or their collateral. And the SBAR handover I spoke about in the human factors already, which is how you will hand over a patient either to another A&E colleague or to your inpatient team. And I realize I've just whizzed through that, but I thought I'd leave time for questions or any cases that you wanted to discuss.
So are there any times when you kind of would, I guess, override the A to E situation? So for example, I was recently taught about managing anaphylaxis, and we're told to complete A to E before managing it, giving adrenaline and things. But it's kind of like, why would you not just, as soon as you've got the diagnosis, treat it with adrenaline for something like that, which is quite quick to
You're actually
work?
doing A to E, but you're just doing the non-trauma version of it, which is essentially the medical.
Oh.
Patient you see, you're essentially doing an A to E in the first 5 minutes without necessarily realizing it. So the main problem with anaphylaxis is, what part of A to E are you worried about with anaphylaxis?
I guess airway.
Absolutely. So then, and you can't fix B if you don't fix A.
Sure.
So if you've realized it's anaphylaxis, you're still literally in 1 to 2 minutes going to do your A to E assessment and then do your intervention / treatment for each of the A, B, C, D.
Cool. Yeah, that makes sense.
For example,
we have a question in the chat as well.
An anaphylaxis will give you an acute stress response, which will push your sugar up, even in a normal person that doesn't have underlying diabetes, more so in a person with diabetes. And then they could go into a steroid crisis, sorry, not a steroid crisis, into an hypoglycemia, especially if they've got underlying adrenal crisis or adrenal or Addison issues, that push them into something that needs steroids immediately, which we would be given for anaphylaxis anyway.
There's a question in the chat as well. How can we determine GCS in pediatrics?
Exactly the same as adults. Or you can cheat and use MD calculator. So just type in GCS on your phone and there should be an MD calculator. Also, what's probably more useful in a child is essentially in a child that's unresponsive and not withdrawing with putting in a line. If you're going intraosseous, you've got a problem, call for help. That child most likely needs some sort of intubation. So I've just been asked, how can we minimize the extrinsic load if we're living in a stressful area and stressful environment? I think the most important thing, like I said earlier, is you need to find a coping mechanism to cope. Easier said than done. And I think, especially for me, it's something I've always struggled with. I'm a perfectionist. I'm not used to failing. I'm not good with failing. I'm not good with leaving my work at work. I would come home and then everybody at home needs to know how rubbish my day has been, or likewise how good my day has been, because that's just how I am. the one downside of A&E is that you can't necessarily follow up your patients. And I know my colleagues love that aspect. That's the one aspect I hate, because there's no continuity of care. And that's an additional burden where I then feel like I need to go back the next day. I'll go back earlier or stay later to then find out what's happened to my patient. So I think you need to realize what's healthy and what's acceptable for you and how much you can cope with. So you need to realize what your own coping mechanisms are and how much you can deal with before you realize it's just too much. I think I've answered that question. Regarding a 2-year-old child, how would you determine his GCS? So if he's moving and doing everything that he needs to be doing, he's most likely 15. But with a 2-year-old or any young patient, it's often useful to have a parent or a sibling or someone around that can tell you this child is away from their baseline. And essentially there's a slightly modified GCS in children, but that's not going to significantly change your management, because by the time you're assessing their GCS, you would have already done their AV-PU score, your AV, so I have no idea how to make this mute with my WhatsApp, your AV-PU score. So if they're already alert, you're not worried. If they're responding to verbal, then you need to then ascertain, is it enough, or you're happy with, or is it something you're going to intervene in? And if you're assessing a GCS in a child, 90% of the time you'll be having senior help there already, because hopefully this has been something that's been escalated or pre-alerted. So you shouldn't be completely alone needing to do it. That said, do a decompression for tension pneumothorax outside the hospital without a needle with a screw. I definitely wouldn't use a screw. I have done one with a pen and a straw back home in South Africa, but that's because I am pre-hospital trained and I would be covered if anything went wrong. I definitely would not advertise that or recommend anybody else to do it. I know we see a lot of it on Grey's Anatomy and House and ER, but I definitely would stay away from it. And I think it would essentially be what you are covered for medico-legally. That's where I would go with that. One more question, is ABC still the order in an unconscious patient, or will it be CAB? If they're unconscious with a pulse, it's still ABC. If they're unconscious with no pulse, then it's compressions, airway, breathing. So unconscious with a pulse or unconscious without a pulse, that will determine ABC or CAB. It's a really good question. I'm very impressed that you've asked that. How do I deal with death of a patient, especially if something could have been differently to save their life? So I cry. I cry a lot. I often don't cry at the time. I have this weird delayed reaction, which has always been me, whether it's to personal grief or professional grief. I love writing, so I write about it, I journal. That's one of my coping mechanisms. I love painting and drawing. That's another coping mechanism. I dance, and I talk about it with my supervisor a lot. My supervisor is amazing. I've been very blessed to have such a lovely supervisor. And I think I talk about it with the other team members involved, and we debrief, and the hot and cold debrief is really useful. We talk about it at the time and then 2 weeks down the time as well. And I don't think it ever gets easier. I still remember the ones that have really touched me, and then I try and use them as cases to teach, which then that way a little part of them is always with me, and then I do their death some justice. I try. But yeah, I think the older I've gotten, that's something I've struggled with. It's something I thought that would get easier, but it really doesn't. And just to put things in perspective, our head of department yesterday was in tears because we lost a 29-year-old who's significantly older than me. I'm in my mid-30s, and it was just really humbling to see that even older people that have been practicing medicine for a lot longer than 12 years, which is what I've been practicing, still get touched and still get upset. And again, I think it's really okay to realize that you're not okay, and then just take a minute, take an hour, take the day off. And that's something I've learned a lot over the last year. Thank you for all your individual comments. I've just been inundated with a flood of messages to say thank you. Very much appreciated. Yeah, I think that is it. Thank you very much again, and I wish you all the best. And I hope our paths do meet one day.
Well, thank you very much. I'm going to close the meeting down now. Any more questions, send them to Dr. Dole or to us. Great. Thank you very much. Thanks, Dr. Dole. Bye.